Hello everyone. So today we will be doing chapter 12 of illustrated textbook of Pediatrics, that is growth and puberty. Features of growth and puberty are growth is a key element of child health. It should be considered whenever children are seen. The growth of all children should be monitored regularly, especially during the first months of life, and recorded on the growth charts in the parent health, personal child health record. Knowledge about normal growth and pubertal development is required for deviation from the norm to be recognized. Deviation of growth from expected centiles or the normal sequence of pubertal development requires further assessment. Normal growth, there are four phases of normal human growth. Fetal, this is the fastest period of growth, accounting for about 30% of eventual height. Size at birth is determined by the size of the mother and by placental nutrient supply, which in turn modulates fetal growth factors, insulin-like growth factor 2, IGF-2, human placental electrogen and insulin. Optimal placental nutrient supply is dependent on an adequate maternal diet. Size at birth is largely independent of the father's height and of growth hormone. Severe intrauterine growth restriction and extreme prematurity, when accompanied by poor postnatal growth, can result in permanent short stature. Paradoxically, low birth weight increases the later metabolic risk of childhood obesity. Infantile phase growth during infancy to around 18 months of age is also largely dependent on adequate nutrition. Good health and normal thyroid function are also necessary. This phase is characterized by rapid but decelerating growth rate and accounts for about 15% of eventual height. By end of this phase, children have changed from their fetal length, largely determined by the uterine environment, to the genetically determined height. An inadequate rate of weight gain during this period is called faltering growth. Childhood phase, this is slow, steady, but prolonged period of growth that contributes to 40% of final height. Pituitary growth hormone secretion acting to produce IGF-1 at the epiphysis is the main determinant of the child's rate of growth, provided there is adequate nutrition and good health. Thyroid hormone, vitamin D, and steroids also affect cartilage cell division and bone formation. Profound chronic unhappiness can decrease GH secretion accounts for psychosocial short stature. Pubertal growth spurt, sex hormones, male testosterone and estradiol, cause the back to lengthen and boost growth hormone secretion. This adds 15% to final height. The same sex steroids cause fusion of the epiphyseal growth plates and a cessation of growth if puberty is early, which is not uncommon in girls. The final height is reduced because of early fusion of the epiphyses. Measurement. Growth must be measured accurately with attention to correct technique and accurate plotting of the data. Weight, readily and accurately determined with electronic scales, but must be performed on a naked infant or a child dressed only in underclothing, as an entire month's or year's weight gain can be represented by a wet nappy or heavy jeans, respectively. This is a figure showing male and female high velocity charts, 50th percentile, showing the determinants of childhood growth. The fetal infantile phases are mainly dependent on adequate nutrition, whereas the childhood and pubertal phases are dependent on general health, growth hormone, and other hormones. Adult males are taller than females as they have a longer childhood growth phase. Their peak height velocity is higher and their growth ceases later, showing fetal, which accounts for 30% of adult height. Uterine environment, infant 15% of adult height. Nutrition, good health and happiness, thyroid hormone, childhood 40% of adult height. Genetics, good health and happiness, growth hormones and thyroid hormones, and pubertal 15% of adult height, testosterone, estrogen, growth hormone. Height, the equipment must be regularly calibrated and maintained. In children over 2 years of age, the standing height is measured as illustrated. In children under 2 years, length is measured lying horizontally using the parent to assist. Accurate length measurement in infants can be difficult to obtain as the legs need to be held straight and infants often dislike being held still. For this reason, routine measurement of length in infancy is often omitted from child surveillance, but it should always be performed whenever there is doubt about an infant's growth. Height circumference. The occipitofrontal circumference is a measure of head and hence brain growth. Plot the maximum of 3 measurements. It is of particular importance in developmental delay or suspected hydrocephalus. Body mass index. BMI calculates this using height in square meters per weight in kilogram and plot on a gender-specific body mass index centile chart to assess the underweight or obese children. These measurements should be plotted as a simple dot on an appropriate growth centile chart. Standards for a population should be constructed and updated every generation to allow for the trend towards early puberty and taller adult stature from improved childhood nutrition. In 2009, the UK adopted the World Health Organization new global child growth standards for infants and children 0 to 4 years old. The new charts are based on the optimal growth of healthy children exclusively breastfed up to the age of 6 months. These charts allow for the lower weight of exclusively breastfed infants and therefore reduce the number of breastfed babies labeled as underweight and may also allow earlier identifications of formula fed babies gaining weight too rapidly. Height in the population is normally distributed and the deviation from the mean can be measured as a centile of standard deviation. The bands on the growth reference charts have been chosen to be 2/3 of an ST apart and corresponds approximately 25th, 9th, 2nd, and 0.4 centiles below the mean and 75th, 91st, 98th, and 99.6 centile above the mean. The further the centiles lie from the mean, the more likely it is that child has a pathological cause for his or her short or tall stature. For instance, values below the 0.4 or above the 99.6 centile will occur by chance in only 4 per 1,000 children can be used as a criterion for referral from primary to specialist care. A single growth parameter should not be assessed in isolation from the other growth parameters. For example, a child's low weight may be in proportion to the height if short but abnormal if tall. Serial measurements are used to show the pattern. This is the measuring length in infants and young children. An assistant is required to hold the leg straight. And this is the mean centile chart. Interpretation of UK growth reference charts. Lines show the mean and bands, which are 2/3 of the standard deviation apart. The centiles are shown in the diagram. The serial measurements, which are used to show the pattern and determine the rate of growth. This is helpful in diagnosing or monitoring many pediatric conditions. The child's growth should be assessed in the context of his or her family size. Heights from both biological parents should be used to calculate mid-parental height in the child's target range. Now, the summary measurement of children. Measurements must be accurate for meaningful monitoring of growth. Growth parameters should be plotted on charts. Significant abnormalities of height or measurement below the 0.4 or above the 99.6 centile outside the mid-parental height range. If markedly discrepant from weight, serial measurements which cross growth centiles lines after the first year of life. The pattern of growth is essential information when assessing the health of a child. Consider genetics, nutrition, general health, and hormones and potential cause of abnormal growth. Now, puberty follows a well-defined sequence of changes that may be assigned stages, as shown in the figure in both figures. Over the last 20 years, the mean age at which puberty starts in girls has lowered. However, the age at which menarche occurs has remained stable. Therefore, females now remain in puberty for longer. In females, the features of puberty are breast development, palpable breast tics, and the first sign, usually starting between 8.5 and 12.5 years. Pubic hair growth and rapid height growth occurs almost immediately after breast development. This is stages of puberty, female breast changes, and pubic hair changes, female and male. Phases showing categorized and schematic drawings of males and female stages are shown according to the Tanner stages of puberty. These are called the Tanner staging of puberty. B1 is prepubertal, B2 is breastbud, B3 juvenile smooth contour, B4 is areola and papilla project above breast, and B5 as an adult. Now, male genital stages. Page 1, pre-adolescent, no sexual hair. Page 2, sparse, pigmented, long, straight, mainly along labia or at the base of penis. Page 3, dark goes curlier. Page 4, filling outwards, adult distribution. Page 5, adult in quantity and type with spread to medial thighs in male. Male genital stages, and this is G1, pre-adolescent. G2, lengthening of the penis. G3, further growth in length and circumference. G4 is development of glans penis, darkening of scrotal skin, and G5 is adult genitalia. Menarche occurs on average 2.5 years after the start of puberty and signals that growth is coming to an end with only around 5 centimeter height gain remaining. In males, testicular enlargement to over 4 ml volume measured using an orchidometer, the first clinical sign of puberty. Pubic hair growth follows testicular enlargement, usually between 10 years and 14 years of age. Rapid height growth when the testicular volume is 12 ml to 15 after a delay of around 18 months. The growth spurt in males occurs later, is of greater magnitude than in females, accounted for the greater final average height of males than females. This is the timing of puberty, the chart showing uh, pubertal changes are shown according to a Dana staging of stages of puberty, and these are the Dana staging. Female females, height of growth for is 12 years, age of menarche is 12 and a half, 12 quarter to 12 half. Breast stage is 4 and 3 and 2. Pubic hair is 4, 3, 2 shown, and then it is male, height of growth spurt 14 years, penis stage showing testicular volume 4 ml, then 12 ml, and pubic hair stage 2, 3, 4. And these are the x-rays of the left and wrist and hand to determine bone ages. This technique allows assessment of skeletal maturation time of uh, from the time of appearance of maturity of the epiphyseal centers. Using a standardized rating system, the child's height can be compared with skeletal maturation and adult height prediction made. The ages show bone age of each x-ray. And this is a archidometer to assess testicular volume in ml. In both sexes, there will be development of acne, axillary hair, body odor, and mood changes. If puberty is abnormally early or late, it can be further assessed by bone age measurement from hand and wrist, X-ray to determine skeletal maturation. In females, pelvic ultrasound can be used to assess uterine size and endometrial thickness. Menstruation has a wide range of normal variation. The normal cycle length varies between 21 days and 45 days. The length of blood loss varies between 3 days and 7 days, and average blood loss cycle is less than 80 ml. Passage of blood clots or the use of more than 6 baths per day implies heavy bleeding, which needs evaluation. Rarely, it can indicate clotting disorders such as von Willebrand disease. Summary: puberty, the first sign of female puberty is a palpable breast bud. The first sign of male puberty is testicular volume over 4 ml. In females, the height spurt occurs shortly after breast development. Males starts almost 18 months after the first sign of puberty. Now, short stature usually defined as the height below the second centile to standard deviation below the mean. Most of these 1 in 50 children would be normal, though short with short parents. However, the further the child is below these centiles, the more likely it is that there will be a pathological cause. Only 1 in 250, 4 in 1000 children are shorter than the 0.4th centile, minus 2.6 deviation, and these should be assessed for a cause. However, the rate of growth may be abnormal a long time prior to the child's height being below these values, this growth failure can be identified from the child's height falling across centile lines plotted on a height velocity chart. This allows growth failure to be identified whilst child's height is still above the second centile. Measuring height velocity is a sensitive indicator of growth failure. Two accurate measurements at least 6 months, but preferably a year apart, allow calculation of height velocity in centimeter per year. This is plotted at the midpoint in time on a height velocity chart. Disadvantage of using height velocity calculation is that they are highly dependent on the accuracy of the height measurement and so tend not to be used outside specialist growth clinics. The height centile of a child must be compared with the weight centile and an estimate of his or her genetic expected height calculated from the height of his or her and of his or her parents. This is calculated as the mean of others and mother's height, with 7 centimeter added for the midparental target height of a boy and 7 centimeters subtracted from a girl. The 9th to 91st centile range of this estimate is given by 10 plus minus 10 centimeter in a boy and plus minus 8.5 centimeter in a girl. More short children are psychologically well adjusted to their size. However, there may be problems from being teased or bullied at school, poor self esteem, and they're likely to be at a considerable disadvantage. In most competitive sport, they are also assumed by adults to be younger than their true age and may be treated inappropriately. Familial, most short children have short parents and fall within the centile target range, allowing for mid-parental height. Care needs to be taken, though, that both the child and parent do not have inherited growth disorders such as skeletal dysplasia. Constitutional delay in growth and puberty. Constitutional delay in growth and puberty is a variation of normal growth which presents with short stature in teenage years because of a delay in the onset of puberty. Growth during childhood is usually within the lower limits of normal. Bone age is somewhat delayed, and onset of secondary sexual development is delayed, but final height is normal. There is usually a family history of delayed growth in puberty, but normal height as adults. Small for gestation is extreme prematurity. About 10% of children born small for gestation age or who were extremely premature remains short. Growth hormone treatment may be indicated if there is insufficient catch-up growth by 4 years of age. Chromosomal disorder syndromes. Many chromosomal disorders and syndromes are associated with short stature. Down syndrome is usually diagnosed at birth, but Turner, Noonan, and Russell-Silver syndromes may present with short stature and minimal symptoms. Turner syndrome may be particularly difficult to diagnose clinically and should be considered in all short females. Nutritional long-term illness is a relatively common cause of abnormal growth. These children are usually short and underweight, i.e., their weight is on the same or a lower centile than their height. Inadequate nutrition may be due to insufficient food, restricted diets, or poor appetite associated with the long-term illness, or from the increased nutritional requirement from a raised metabolic rate. Chronic illnesses that may present with short stature include celiac disease, which usually presents in the first 2 years of life, but can present late with faltering growth. Celiac disease may result in short stature without gastrointestinal symptoms. Crohn's disease, chronic kidney disease may be present in the absence of a history of renal disease. Cystic fibrosis, malabsorption, recurrent infections, increased work of breathing, and reduced appetite. Congenital heart disease, increased work of breathing. Now, these causes in evaluation: short stature, causes familiar following growth centile within predicted range for parental height, severe and retardation of prematurity, short from birth, normal mid-parental height, constitutional delay of growth and puberty, short stature accentuated by delayed puberty, delayed bone age, endocrine, hypothyroidism, growth hormone deficiency, steroid axis, iatrogenic, Cushing syndrome, IGF-1 deficiency, falling of height centiles, weight centile more than height centile, short and overweight, markedly delayed bone age. These are the causes of short stature. Causes and evaluation of short stature: nutrition, long-term illness, GIT, celiac, Crohn's, chronic kidney disease, and psychological, emotional deprivation, neglect. Falling of height centiles, weight centile, less in height centile, delayed bone aging syndrome, Turner Noonan, Down Russell Silver dysmorphic features. This is a picture of Russell Silver syndrome and extreme short stature, which is rare. And then it is disproportionate skeletal dysplasia, legs more than back, and storage disorders back more than legs. Now, psychosocial deprivation. Children subjected to physical and emotional deprivation may be short and underweight and show delayed puberty. This condition may be extremely difficult to identify, but affected children show catch-up growth if placed in a nurturing environment. Endocrine hypothyroidism, growth hormone deficiency, IGF-1 deficiency, and steroid access are uncommon causes of short stature. They are associated with children being relatively overweight, i.e., their weight on a higher centile than their height. By contrast, children with nutritional obesity tend to be relatively tall compared with mid-parental height range. Hypothyroidism is usually caused by autoimmune thyroiditis during childhood. This produces growth failure, usually with excess weight gain. It may go undiagnosed for many years and lead to short stature. When treated, catch-up growth rapidly occurs, but often with a rapid entry into puberty that can limit final height. Congenital hypothyroidism is diagnosed soon after birth, but a neonatal biochemical screening and with treatment does not result in any abnormality of growth. Growth hormone deficiency, this may be isolated, secondary to wide pituitary dysfunction. Pituitary function may be abnormal in congenital, midfacial, or midline defects, or as a result of a craniopharyngioma, a tumor affecting the pituitary region, a hypothalamic tumor, or trauma such as head injury, meningitis, and cranial irradiation. Craniopharyngioma usually presents in late childhood and may result in abnormal visual fields, characteristically a bitemporal hemianopia as it impinges on the optic chiasm, optic atrophy, or papilledema or fundoscopy. Laron syndrome is a condition due to defective growth hormone receptors resulting in growth hormone insensitivity. Patients with this condition have high growth hormone levels but low levels of the downstream active product of growth hormone known as IGF-1 produced at the growth plate and then the liver. Rare abnormalities in gene producing IGF-1 have recently been discovered in children. Corticosteroid axis Cushing syndrome. This is usually iatrogenic as corticosteroid therapy is a potent growth suppressor and a number of chronic conditions are treated with corticosteroids. This effect is reduced by alternate day therapy, but some growth suppression may be seen even with relatively low doses of inhaled or topical steroids in susceptible individuals. Non-iatrogenic Cushing syndrome is very unusual in childhood and may be caused by pituitary or adrenal pathology. Growth failure may be very severe and is accompanied by excess weight gain, although normalization of body shape and height occurs on withdrawal of corticosteroid therapy or treatment of the underlying steroid axis. Cushing syndrome during puberty can result in permanent loss of height. Extreme short stature. There are few rare conditions that cause extreme short stature in children. Idiopathic short stature refers to short stature that does not have a diagnostic explanation. In addition, abnormalities in a gene called short stature homeobox located on the X chromosome leads to severe short stature skeletal abnormalities, and when present on both copies of gene, absence of one shock gene in Turner syndrome is thought to be the cause of short stature. In this condition, and additional copies in Klinefelter produce taller than normal stature. Polymorphism in this gene probably accounts for a proportion of idiopathic short stature. Now, disproportionate short stature. This is confirmed by measuring sitting height based on spine to the top of head, subischal leg length, subtraction of sitting height from total height, limited radiographic skeletal survey to identify the skeleton abnormality. Charts exist to assess the normality of body proportions. Conditions with abnormal body proportions are rare and may be caused by disorders of the formation of bone. Skeletal dysplasia, they include achondroplasia and other short-limbed dysplasias. If the legs are extremely short, treatment by surgical leg lengthening may be appropriate. The back may be short from severe scoliosis or some storage disorders such as mucopolysaccharidosis. Examination investigation, plotting present and previous heights. and weights on appropriate growth charts together with the clinical features usually allow the cause to be identified without any investigation. Previous height and weight measurements should be available from the parent health personal child health record. The bone age may be helpful as it is markedly delayed in some endocrine disorders, for example, hypothyroidism or in growth hormone deficiency, and is used to estimate adult height potential. Investigations that may be indicated are shown in table. Investigations considered for short stature. These are investigations. X-ray of the left hand and wrist for bone age, some delay in constitutional delay of growth in puberty, marked delay for hypothyroidism, growth hormone deficiency, full blood count, anemic and celiac and Crohn's disease. Creatinine electrolytes, creatinine raised in chronic kidney disease, calcium phosphate, alkaline phosphatase, renal and bone disorders, thyroid stimulating hormone, raised in primary hypothyroidism, karyotype, Turner syndrome shows 45XO, other chromosomal disorders, anti-endometrial EMA and anti-TTGA, usually present in celiac disease, antibodies, immunoglobulin A antibodies, and then there's a CRP, acute phase reactant erythrocyte sedimentation rate, which is raised in Crohn's disease, growth hormone provocation test using insulin, glucagon, clonidine, arginine in specialist centers. These show growth hormone deficiency, IGF-1, disorder of the growth hormone axis, including IGF-1 deficiency. 9-hour morning cortisol and dexamethasone suppression test, which is Cushing syndrome, MRI scan, if neurological symptoms, signs, limited skeletal survey, which is skeletal dysplasia and scoliosis. Growth hormone treatment of short stature. Growth hormone deficiency treated with biosynthetic synthetic growth hormone, which is given by subcutaneous injection, usually daily. It is expensive, and the management of growth hormone deficiency is undertaken at specialist centers. Best response is seen in children with the most severe hormone deficiency. Other indications include Turner syndrome, Prader-Willi, chronic kidney disease, Shark's deficiency, and intrauterine growth restriction, or small for gestation age with failure of catch-up growth in Prader-Willi syndrome, an imprinting disorder resulting in early hypotonia and feeding difficulties, followed by short stature, obesity, and learning difficulties. Growth hormone improve muscular strength and body composition, as well as modesty, improving final height. Recently, recombinant IGF-1 has been used to treat children with growth hormone resistance, for example, Lawrence syndrome and IGF-1 deficiency, who would have previously not responded to growth hormone treatment. Recombinant IGF-1 therapy is still very expensive, is confined to a very few specialized centers. The case history. Turner syndrome, the girl presented when 10-year-old with short stature. She has a history of recurrent ear infection, but was otherwise well. She has always been very short, and height was 126.4 centimeter, well below the 0.4th centile on the standard growth chart. Her chromosome was checked, which confirmed Turner syndrome 45XO. She was started on growth hormone injection and on ethinyl estradiol, estrogen for pubertal induction at 14 years of age. At 15 years of age, height was 150 centimeter. This picture, clinical features of Turner syndrome is stating the need to check the karyotype with marked short stature. Now the summary. Assessment of the child is short stature. This is the first examination of growth chart following growth centile lines for length, height, parent head circumference. Consider familial low birth weight, constitution delay and puberty and syndromes and skeletal dysplasia, faltering growth or crossing of centile lines. Consider endocrine, including therapeutic, corticosteroid, nutrition, chronic illness, psychosocial deprivation. Determine the midparental height for genetic target range. History, birth, length, weight, head circumferences, and gestation age, pregnancy history, infection, intrauterine growth restriction, drug use, alcohol, smoking, feeding history, developmental milestones, family history of constitution, delay of growth, and puberty or other diseases, consanguinity pertaining to inherited conditions, features of chronic illnesses, endocrine causes, for example, hypothyroidism, pituitary tumor, Cushing syndrome, or psychosocial deprivation, medication, for example, corticosteroids, examination, dysmorphic feature chromosome syndrome present, but in Turner syndrome, other stigmata may be absent. Chronic illness, for example, Crohn's, cystic fibrosis, celiac disease, evidence of endocrine causes, disproportionate short stature from skeletal dysplasia, pubertal stage. Diagnosis cause can usually be determined from the above, and no tests are required. Now, tall stature. This is less common presenting a claim than short stature, as many parents are proud that their child is tall. However, some adolescents become concerned about excessive height during their pubertal growth sprout. Causes are presented in the table. Most tall stature is inherited from tall parents. Obesity in childhood fuels early growth and may result in tall stature. However, because puberty is often somewhat earlier than average, it does not increase final height. Secondary endocrine causes are rare. Both congenital adrenal hyperplasia and precocious puberty lead to early epiphyseal fusion, so that eventual height is reduced after an early excessive growth rate. Marfan, a disorder of loose connective tissue, and Klinefelter, excess Y and excesses of Shock-Stokes syndromes both cause long-legged tall stature, and in XXY there is also infertility and learning difficulties. Tall children may be disadvantaged by being treated as older than their chronological age. Excessive height is in prepubertal or early pubertal adolescent females and males can be treated with estrogen therapy and testosterone therapy, respectively, to induce premature fusion of the epiphysis, but as it produces variable results and has potentially serious side effects, it is seldom undertaken. Surgical destruction of the epiphysis in the legs may also be considered in extreme cases. Abnormal head growth. Most head growth occurs in the first 2 years of life, and 80% of adult head size is achieved before the age of 5 years. This largely reflects brain growth, but small or large heads may be familiar, so comparison with measurements of parents' head should be made at birth. The sutures of fontanelle are open during the first few months of life. The head circumference may increase across centiles, especially if small for gestation age. The posterior fontanelle has closed by 8 weeks and the anterior fontanelle by 12 months to 18 months. If there is a rapid increase in head circumference, raised intracranial depression should be excluded. Now, the cause of excessive growth or tall stature, familial, most common cause, obesity, puberty is advanced, so final height centile is less than in childhood. Secondary hypothyroidism, excess sex steroids, precocious puberty from whatever cause, excess adrenal androgen steroids, congenital adrenal hyperplasia, true gigantism, excess growth hormone secretion syndromes, long-legged, tall stature. Marfan, homocystinuria, Klinefelter 47XXY karyotype, Soto syndrome associated with large head, characteristic of facial features, and learning difficulties, excessive growth at birth, proportionate tall stature at birth, maternal diabetes, primary hyperinsulinism, and Beckwith syndrome. Microcephaly, head circumference below the second centile, shown in the figure, may be familiar when it is present from birth, and development is usually normal. An autosomal recessive condition when it is associated with developmental delay caused by congenital infection acquired after an insult to the developing brain, for example, perinatal hypoxia, hypoglycemia, meningitis, when it is often accompanied by cerebral palsy and seizures. Microcephaly is a head circumference above the 98th centile. The causes of a large head are listed in box. Most are normal children, and often the parents have large head. Rapidly increasing head circumference, even if the head circumference is still below the 98th centile, suggests raised intracranial pressure and may be due to hydrocephalus, subdural hematoma, or brain tumor. It must be investigated promptly by cranial ultrasound if the anterior fontanelle is still open, otherwise by computed tomography or MRI scan. Bullet point: if an infant's head circumference is enlarging and crossing centile line, check for raised intracranial pressure. Asymmetric head skull asymmetry may result from an imbalance in the growth rate at the coronal, sagittal, or lamproid sutures. Although the head circumference increases normally, occipital plagiocephaly, parallelogram shaped head with flattening of the back of the skull is seen with increased frequency, since the advice to the parents that babies should sleep lying on their back to reduce the risk of sudden infant death syndrome. It improves with time as the infant becomes more mobile. Plagiocephaly is also seen in infants with hypotonia. Preterm infants may develop long, flat heads from lying on their side for long periods. On the hard surface of incubators, this may be moderated by providing the infants with a soft surface to lie on and changing their head position frequently. Under these circumstances, it is not associated with abnormal development. Craniosynostosis, the sutures of the skull bones start to fuse during infancy but do not finally fuse until late childhood. Now, case history in microcephaly figure shows the head circumference chart of Tim, who was healthy and was developing normally. At 9 months of age, he was rushed to hospital. He was unrousable from profound hypoglycemia, secondary to a deliberate administration of insulin by his mother, who had diabetes. Although Tim was taken into care and had no further hypoglycemic episodes, his head circumference shows cessation of growth. He had developed moderate learning difficulty, mild cerebral palsy. This is the Tim head circumference chart. Premature fusion of one or more sutures, craniosynostosis, may lead to distortion of the head shape. Craniosynostosis is usually localized. It most often affects the central suture when it results in a long, narrow skull. Rarely it affects the lambda suture to result in skull asymmetry, which needs to be differentiated from the plagiocephaly, where there is asymmetric flattening on one side of the skull from positional molding. Causes of large head, tall stature, familial microcephaly, reason integrated pressure in infant, chronic subdural hematoma, brain tumor, neurofibromatosis, cerebral gigantism, Soto syndrome, and CNS storage diseases, mucopolysaccharidosis, Hurler syndrome, craniosynostosis may be generalized when it may be a feature of a syndrome. The fused suture may be felt or seen as a palpable ridge and confirmed on skull X-ray or cranial computed tomographic scan. If necessary, the condition can be treated surgically because of raised integrated pressure or for cosmetic reasons. Such operations are performed in specialist centers for craniofacial reconstructive surgery. Premature sexual development of secondary sexual characteristics before 8 years of age in females and 9 years of age in males is defined as outside the normal range in the UK. There are several recognized patterns of premature sexual development: precocious puberty, premature breast development, thelarchy, premature pubic hair development, pubarchy or adenarchy, and isolated premature menarche. Precocious puberty may be categorized according to levels of pituitary-derived gonadotrophin, follicle-stimulating hormone, and luteinized hormone. Gonadotrophin-dependent central true precocious puberty from premature activation of the hypothalamic pituitary gonadal axis. The sequence of pubertal development would be normal, described as consonant. Gonadotrophin independent pseudo false precocious puberty from excess sex steroids outside the pituitary gland. The sequence of pubertal development would be abnormal. Described as dissonant. Female, the ovaries are very sensitive secretion of gonadotrophins from the pituitary gland. So gonadotrophin dependent precocious puberty is fairly common in girls. It is usually idiopathic or familial. Pathological causes of precocious puberty in girls are rare and can be secondary to either gonadotrophin independent causes such as access androgens from congenital adrenal hyperplasia or adrenal tumors presenting with pubic and axillary hair, a dull body odor, acne, and realization of the genitalia before breast development. Gonadotrophin dependent causes such as pituitary adenoma, where pubertal development will be constant but perhaps rapid. Ultrasound examination of the ovaries and uterus is helpful in assessing the progress of puberty. The uterus will change from an infantile tubular shape to pear shape with the progression of puberty, and the endometrial lining can be identified close to menarche. Precocious puberty in females is usually due to premature onset of normal puberty. Males, the testes are relatively insensitive to secretion of gonadotrophin from the pituitary gland, so the gonadotrophin-dependent precocious puberty is uncommon in boys. It is important to exclude the pathological cause. Examination of tests can be helpful. Bilateral large testes with testicular volume greater than 4 ml suggests gonadotrophin dependent precocious puberty. This can be caused by intracranial tumor and really by secretion of beta human chorionic gonadotrophin from a liver tumor. Prepubertal testes suggest a gonadotrophin independent cause. For example, adrenal pathology such as a tumor or congenital adrenal hyperplasia, unilateral enlarged testes suggest a gonadal tumor. Tumors in the hypothalamic region are best investigated by cranial MRI scan. Now this shows the abnormal head shape, forms of craniosynostosis, localized sagittal suture, long, narrow skull, coronal suture, asymmetrical skull, lambda suture, flattening of the skull, generalized. Multiple sutures result in microcephaly and developmental delay, genetic syndrome with syndactyly in Apert syndrome with exophthalmos in Cruzon syndrome, normal skull sutures, fused sagittal suture, sagittal craniosynostosis, plagiocephaly, positional molding, hair displaced anteriorly, frontal protuberance and flattening, lambdoidal synostosis, frontal protuberance, ear displaced posteriorly and closed lambdoid. This is differentiated synostosis from plagiocephaly, and this is long flat head of preterm infant. This can be avoided by lying preterm infants on a soft surface and regularly changing their head position. Cruzon syndrome showing the typical shallow orbits and exophthalmos. Craniofacial reconstructive surgery is required to prevent visual loss and cerebral damage from raised intracranial pressure and for cosmetic appearance. Now, this causes a precocious puberty, gonadotrophin dependent and gonadotrophin independent. Dependent includes increased LH, FSH, pituitary, gonad enlarges, estrogen from ovary, and testosterone from testes and adrenal. From pituitary, negative feedback, and that goes estrogen and then causes breast enlargement, gonad shrink or enlarges, gonadal or extragonadal source, testosterone, pubic hair and growth acne, body odor, and breast enlargement. Gonadotrophin dependent signs of puberty are consonant, idiopathic familial CNS abnormalities, congenital anomalies, hydrocephalus acquired post-radiation. Infection, surgery, brain injury, tumors, for example, craniopharyngioma, neurofibromatosis, hypothyroidism, gonadotrophin independent, rare and signs of puberty, often not consonant, adrenal tumors, congenital adrenal hyperplasia, ovarian tumor, granulosa cell, testicular tumor, Leydig cells, and exogenous sex steroids. Now, the bullet point, gonadotrophin dependent precocious puberty in male often has a pathological cause. Management, the management of precocious puberty directed towards detection and treatment of any underlying pathology. For example, use MRI scan to identify an intracranial tumor, particularly in males, reducing the rate of skeletal maturation, which is assessed by bone age. An early growth spurt may result in early cessation of growth and a reduction in adult height. Addressing psychological behavioral difficulties associated with early progression through puberty, deciding whether to treat a girl who is simply going through puberty early needs further consideration. If treatment is required to delay the onset of menarche, gonadotrophin releasing hormone analogs are the treatment of choice. In gonadotrophin independent case, the source of excess sex steroids needs to be identified. Inhibitors of androgens or estrogen production or action, for example, medroxyprogesterone acetate and cyproterone acetate, testolectone, and ketoconazole may be used. Premature breast enlargement. The larvae disability affects females between 6 months and 2 years of age. The breast enlargement may be asymmetrical and fluctuate in size, really progressing beyond stage 3 of puberty. It is differentiated from gonadotrophin dependent precocious puberty by the absence of axillary pubic hair and of a significant growth spurt. It is non-progressive and self-limiting. Investigations are not usually required. Premature puberty Adrenarche, this occurs when pubic hair develop before 8 years of age in females and before 9 years in males, but with no other signs of sexual development. It is most commonly caused by an accentuation of the normal maturation of androgen production by the adrenal gland between the age of 6 years and 8 years. It is more common in Asian and Black children. There may be a slight increase in growth rate and bone age by 12 to 15 months. It is usually self-limiting. A more aggressive course of realization would suggest non-classical congenital adrenal hyperplasia or an adrenal tumor. Obtaining a urinary steroid profile evaluating levels of androgens in the blood and measuring bone age help differentiate premature puberty from non-classical congenital adrenal hyperplasia or an adrenal tumor. Girls who develop premature puberty are an increased risk of developing polycystic ovarian syndrome in later life. Now, the case history gonadotrophin dependent precocious puberty in a boy. This 6-year-old boy presented precocious puberty. He was noted to have multiple Capsular spots consistent with a diagnosis of neurofibromatosis type 1. An MRI scan showed a mass in the hypothalamus, which proved to be an optic glioma. He was treated with radiotherapy, and although full remission was not possible to achieve, the site of injection of gonadotrophin superagonist treatment to suppress his sexual development is covered by the plaster. This multiple Capsular spots, neurofibromatosis type 1 is diagnosed. Genitalia showing stage 3 genitalia and pubic hair with 12 ml testicles. Bilateral, he also had adult body odor. Case history 12.4, this 18-month-old female developed enlargement of both breasts. There was no pubic hair growth, fattiness, or body odor, and height was in the mid-parental range. Her bone age was only mildly advanced during 1 month. Her subsequent growth rate was normal. A diagnosis of premature thalarchy was made, and this is premature breast development in an 18-month-old girl. Delayed puberty often defined as absence of pubertal development by 14 years of age in females, 15 years in males. The causes of delayed puberty are listed in box 12.3. In contrast to precocious puberty, delayed puberty is more common in males due to relative insensitivity to testosterone gonadotrophin secretion. Most commonly, this is constitutional delay in growth in puberty, often with a family history of delayed puberty. It is a variation of normal timing of puberty rather than a pathological condition. It may be induced by dieting or excessive physical training. An affected child will have delayed sexual changes compared with his or her peers, and bone age would show moderate delay. The legs will be long in comparison to the back, and eventually the target height will be reached as growth is affected. In affected children will continue for longer than in the peers. The condition may cause psychological upset from teasing, poor self-esteem, disadvantages in the competitive sport. In boys, assessment include pubertal staging, especially testicular volumes, identification of long-term systemic disorder. Now, these are the causes of delayed puberty: constitutional delay of growth and puberty familial. By far the most common: low gonadotrophin secretion, hypogonadism, systemic disease, cystic fibrosis, severe asthma, Crohn's disease, organ failure, anorexia nervosa, starvation, excess physical training, hypothalamo-pituitary disorders, pituitary dysfunction, isolated gonadotrophin or growth hormone deficiency, intracranial tumors, including craniopharyngioma, Kallmann syndrome, luteinizing hormone releasing, hormone deficiency, inability to smell, acquired hypothyroidism, high gonadotrophin secretion, hypogonadotrophic hypergonadism, chromosomal abnormalities, Klinefelter syndrome, 47XXY, Turner syndrome, 45XO, steroid hormone enzyme deficiency, acquired gonadal damage, post-surgery, chemotherapy, radiotherapy, trauma, torsion of the testes, autoimmune disorder, case history, constitutional delay in growth. 15-year-old boy is concerned that he's short, he's well, but gets teased at school about his height. His mother had menarche, and 13 years of age, father recalls that he was still growing when he left school at the age of 16 years. Examination reveals stage 1 pubic hair and testicular volumes of 4 ml bilatery. His bone is delayed by 18 months as his mood has been significantly affected by his delayed puberty. He's treated with testosterone for 8 months with good effect on his growth rate and confidence. He then continues to make pubertal progress independently and reaches a final adult height of 179 centimeter. Following reassurance that puberty will occur, treatment is usually not required. Should treatment be wanted, oral oxandrolone can be used in young males. This weak androgenic anabolic steroid will induce some catch-up growth but not secondary sexual characteristics. In old boys, low-dose intramuscular testosterone will accelerate growth as well as inducing secondary sexual characteristics. In girls, as the ovaries are sensitive gonadotrophin, delayed puberty is less common, and an organic cause should be excluded. Karyotyping should be performed to identify Turner syndrome and thyroid, and sex steroid hormones should be measured. Consider the possibility of eating disorder and pituitary pathology. The aims of management are to identify and treat any underlying pathology, ensure normal psychological adaptation to puberty and adulthood, accelerate growth, and induce puberty if necessary. Female may be treated with estradiol for several months to induce puberty. Summary: delayed puberty is common in boys and usually due to constitutional delay in growth and puberty. Delayed puberty is uncommon in girls and a cause should be sought. Thank you very much.